Hi everybody. So today's topic of discussion in this audiobook is neonatal sepsis. It is second most common cause of neonatal mortality after prematurity. And the common organisms which are implicated for the neonatal sepsis in India is Klebsiella, followed by Staphylococcus aureus and E. coli. In worldwide situation, it is group B streptococci. Now, once we know that neonatal sepsis, the presentations of sepsis can be within 72 hours of life or it may be after 72 hours of life. By that, we can divide neonatal sepsis into early onset sepsis and late onset sepsis. Early onset sepsis, as I told you, it is within 72 hours of life, and that is generally because the source of infection is from the mother. And the most common maternal infection is your chorioamnionitis, where there will be history of high fever in mother with foul smelling liquor. This is because the infection is passing either from the uterus or through the birth canal, and the neonate is getting infection. That is what is early onset sepsis is. After chorioamnionitis, also if there is preterm premature rupture of membrane, or if the rupture of membrane that happens more than 24 hours, that is also responsible for early onset sepsis. Where in case of late onset sepsis, it is quite nosocomial or hospital acquired because of the frequent handling of the babies by the healthcare personnel because of the unclean hands, and that is why the most preventable cause for late onset sepsis or overall neonatal sepsis is unclean hands. So the hand hygiene is the maintenance of hand hygiene is very important in the prevention of neonatal sepsis. Coming to the long term sequelae that you can get from neonatal sepsis. From early onset neonatal sepsis, pneumonia and respiratory distress can happen, where in case of late onset sepsis, two important aspect that you need to know is septicemia and meningitis. Also there may be pneumonia. Now, the diagnosis of the neonatal sepsis is presence of clinical features of sepsis along with bacteremia. So, any sick baby, you should suspect sepsis and start IV antibiotics. No single most important clinical feature is diagnostic in neonatal sepsis. The early features that you will get altered feeding pattern, lethargic baby, and the most reliable feature is your hypothermia. That is very important. In case of sepsis in adult, you will get hyperthermia, but here it is very important hypothermia in neonatal sepsis. Manifestations of affected organ system like respiratory distress, seizure, etc. are also added symptoms that you can get. The gold standard in diagnosis is blood culture that will generally take 48 to 72 hours to get the report. Meanwhile, you should start empirical antibiotics. Sometimes screening of the sepsis can also be done using 5 components. Number 1, total leukocyte count. 2 is your absolute neutrophil count. 3 is immature to total neutrophil ratio. Number 4 is micro ESA, and number 5 is CRP, that is C reactive protein. Now, any two is significant among these four is your sepsis screen positive. But sepsis screening has a very high negative predictive value that helps us ruling out the infection. So, if sepsis screen is negative, that means there is absence of disease. But if screening is positive, it cannot confirm it. So, we have to go for blood culture to confirm the sepsis. Okay. Next point regarding the components that you need to remember कि generally in adult if we say sepsis, that means the WBC count, the TLC will increase and also there will be neutrophilia, but that is absolutely opposite in case of neonatal sepsis. You will get TLC that will be decreased less than 5000 per microliter, and your absolute neutrophil count will also be less, and the immature to total neutrophil count will be more than 20%. Micro ESR and CRP, they will be increased because there's an infectious condition, there's inflammation present. So any two is significant makes us that screen for sepsis basically. Now, once we actually diagnose that it is a neonatal sepsis, we can also do some other investigations like chest x-ray. Chest x-ray is actually done if there is any suspected pneumonia, because I told you in long-term cases there may be respiratory distress and pneumonia. And also we can do lumbar puncture if there is basically lumbar puncture is done in all symptomatic babies with suspected or confirmed sepsis, because you need to rule out whether it is a meningitis or something else. Okay, so for all symptomatic babies you need to go for lumbar puncture even if it is a suspected or a confirmed symptom, so confirmed sepsis. For asymptomatic babies, presence of risk factors, lumbar puncture is not required here. Okay, so the management mein I told you कि even before actually getting the blood report in your hand, empirical antibiotic is started, and that is against your gram positive and gram negative bacteria. So we'll start with penicillin and aminoglycosides like ampicillin plus amikacin or ampicillin plus gentamicin that can be given. If there is no response to treatment by 48 hours, or if there is severe infections like you suspect meningitis or septicemia, or the patient is in shock, in that case you should add third generation cephalosporin like ceftriaxone or cefotaxime. Sometimes this may be, I told you कि staphylococcus aureus may be the cause, then you have to add cloxacillin. If it is MRSA, then use vancomycin, add vancomycin. And if it's the patient is in the NICU and there is a high incidence of resistant strain there, so you have to start on pipzo plus amikacin or cefotaxime plus amikacin. Now this is the treatment protocol. I'll be repeating again. But the duration of antibiotic therapy in neonatal sepsis that is asked, remember, if it is culture negative sepsis, so for 1 week. If it is culture positive sepsis but no meningitis, that is for 2 weeks. If it is meningitis, so the treatment duration is 3 weeks. And if it is ventriculitis that is diagnosed by MRI, then the treatment may continue from 4 weeks to 6 weeks. So again repeating, if culture negative sepsis, that means culture negative, it may be screening positive, screening or clinical source that is consistent with the sepsis. Okay, then also it is around 5 to 7 days, remember 1 week. Culture positive 2 weeks, meningitis 3 weeks, and ventriculitis 4 to 6 weeks. Repeating the management again, start with ampicillin, amikacin or gentamicin, then add third generation ceftriaxone, third generation cephalosporin if it is non-responsive by 48 years. अगर कल्चर में आपको स्ट्रेफाइलोकोकस मिल गया तो गिव क्लॉक्सासिलिन, अगर एमआरए से आया तो ऐड वैंकोमाइसिन ओनली. इन केस ऑफ रेजिस्टेंट स्ट्रेन यू हैव टू ऐड piperacillin tazobactam plus amikacin. That's all. Talking about a newer and better marker for inflammation, that is procalcitonin, which is not routinely used in the sepsis screening, but that is obviously a better marker than CRP. Why? Because CRP starts rising after 6 to 12 hours of infection. So obviously we will get a negative value in very early infection. To detect that, we can use procalcitonin because it rises after 4 to 6 hours of infection and peaks at 24 hours. So that is a better marker.